Welcome to Speaking of Midwives, the official podcast of the Journal of Midwifery and Women's Health, where we bring the pages of the journal to life. I'm your host, Melissa Avery. Each episode, we go deep into the evidence, spotlighting the researchers, the breakthroughs, and the midwives leading the science that is transforming reproductive health care. Greetings and welcome to Speaking of Midwives. Today we are talking with Dr. Amy Goh, a nurse midwife and program manager for Birth Center Equity, the Beloved Birth and 50 by 50 initiative. Welcome, Amy.
Hi, Melissa. Thank you so much for having me.
Yeah, we're so glad you could join us today. Would you take just a minute before we get going and tell us about the 50 by 50 initiative?
Yeah, absolutely. So I work for Birth Center Equity right now. They're a nonprofit that's been in existence for about 6 years. And the goal is for there to uplift birth centers that are run by Black, Indigenous, and people of color, particularly midwives of color. And so last year during Birth Center Week, they launched a campaign, the Beloved Birth 50 by 50 initiative. And their goal is by 2050, 50% of babies in the US will come into the world with the care of midwives.
That is awesome.
Yeah.
All right. Well, let's start today and tell us a little bit about your background in midwifery, if you would.
No problem. So I've been a midwife for about 15 years. My journey into midwifery was a little bit circuitous. I initially worked in international development. And during that time, I actually saw my very first birth in Ethiopia, which was attended by a midwife. And at that point, I realized I needed to go back to school to become a midwife. So since then, I've worked in a variety of settings in the Boston and the Cambridge area, ranging from large academic teaching hospitals. I also worked at the Cambridge Birth Center, where I had both my babies. And I currently work per diem at Mount Auburn Hospital. Along that journey, I pursued my PhD, particularly with the goal of improving perinatal outcomes for birthing people of color. I've also been an adjunct faculty at Thomas Jefferson University for the past few years. And as I mentioned, I currently work for Birth Center Equity.
Well, that is terrific. Thanks so much for that. Today, we're going to talk a little bit specifically about an article that you had published in the Journal of Midwifery and Women's Health in 2024, and it was titled Communication Between Pregnant People of Color and Prenatal Care Providers in the United States, an Integrative Review. And let's start by just telling us a little bit about why you wanted to do that review, what inspired you and got you going on that piece of work. And let me just add that not only for the viewers or listeners, not only did Amy write this article and publish it, she also won an author award from JMWH for her article. So congratulations again.
Thanks so much, Melissa. So I think anyone who's worked in midwifery has had multiple encounters of patients, birthing people who've come to them, talking about their experiences. I think for me, working clinically primarily with Black, Latina, and immigrant birthing people over the past decade plus, I've heard many stories of difficulties communicating with their midwives, their OB providers, nurses. And I personally witnessed this myself and also been involved in different types of miscommunication where I needed to reflect on my own interactions with my patients and birthing people. So I've really thought about, during my PhD, sort of how this impacts communication and how we can look at this in a critical way. Particularly now that we have so many different modalities of communication, whether it's face-to-face or via the phone or a patient portal. I really just wanted to get an overview of the experiences of communication of birthing people of color and their communication interactions with their prenatal providers.
Well, thank you. And I agree with you. Communication is so important. I think if people don't feel satisfied with how that went after whatever kind of an encounter in the healthcare system, it just kind of makes everything else much more difficult, doesn't it?
Yeah, for sure.
So your article was an integrative review, and there are many kinds of articles, review articles that people write. I wonder if you could just say something about why you chose to do an integrative review and how that's different and how that worked for you.
Absolutely. I think the integrative review really encompasses not just sort of the quantitative data that's out there. When we think about systematic reviews, they have like very strict criteria and methods answering a very, very specific research question. And so for me, knowing that, some of this has really been like the lived experience of birthing people and their stories of communications that I wanted to capture. In addition to sort of those data-driven, quantitative data-driven manuscripts, I wanted to encompass all of that. And so the interview review really allows for that, summarizing those manuscripts from a variety of sources, from quantitative, qualitative, experimental, the gray literature. And so I wanted a way to be able to encompass all of that.
Sure. Thanks. So you had some specific criteria for selecting articles for the review. So could you share a little bit about that so the listeners will understand the types of studies that informed the review that you completed?
Sure. I mean, as I just mentioned, we did pull from qualitative data. So whether that was people, telling their own lived experience. For example, we had an article talking that I chose discussing the lived experience of Mongolian immigrants seeking prenatal care in the United States. We also have quantitative data, so survey-based. Pregnant people had actually filled out surveys about their communication experiences and satisfaction with communication. And then we also had mixed method studies. So utilizing both those methods, right, and focus group interviews. And so we also had studies that used community-based participatory research methods. So I really used a variety of sources. And so my search terms, because I was looking at communication, of course, involved searching for communication, but patient-provider communication specifically, patient-provider relationships, person-centered care, pregnancy, and this was done during the pregnancy period, the prenatal period. So I really only wanted to encompass that. So those search terms were prenatal care, antenatal care, pregnancy. And then, of course, specifically looking at birthing people of color, pregnant people of color, I then did a wide range of races: Black, African American, Hispanic, Latina, Asian, Pacific Islander, Native American, BIPOC, people of color, and so on, to be able to encompass all of that.
Thank you. In your article, you describe using a technique called memoing as part of your technique for analyzing the data in your articles. I wonder if you'd share a little bit about what that means to the listeners. I think it's helpful for people to have a little bit better understanding of the background, the methods used when they then hear the results and how it might apply to them in their practice.
Absolutely. So memoing is actually a technique that's often used in qualitative research, often grounded theory, actually. And it's really a way to fully engage and like immerse yourself in the research. It's actually a mnemonic. Of course, like when we think of memoing, think of note taking, but actually in this case, like memo, MEMO, is actually a mnemonic for the M for mapping research activities, E, extracting meaning from the data, the M again, maintaining momentum, and the O, opening communication. So as the studies that I ended up doing the final review on were primarily qualitative, I thought the technique would be particularly beneficial for me too, as somebody who's very much of a visual person. I really enjoyed actually mapping out the different themes from all the studies to be able to really identify the specific so the way they interconnect. So after I did review each article, I ended up creating, when we think about memos, right, the different notes for each of those studies, highlighting those key observations. And then after reviewing those memos, I was able to then really hone in on those themes. And then, what was really interesting was that upon reflection of those memos, I thought a little bit more about person-centered care and then person-centered therapy and this idea that there are always factors and outcomes. And so the way that we ended up looking at this literature again was to think about the predefined factors and outcomes, and then ultimately the recommendations as well.
Mm-hmm. Thank you. So I like to ask you to share just the main overview, if you would, of your results and your analysis, and then we're going to come back and kind of go step by step through the parts of the findings, the results that you identified in your work.
Of course. So when you do a type of review like this, thankfully, there's a lot of different tools that we utilized. So I did utilize, once I did the search, a wonderful tool, Covidence, to be able to look at, all the articles and sort through them with my co-author. And we were able to actually looked at over 3,000 articles, but then ultimately included only 26 in our review. 22 were qualitative. and 3 were quantitative, and then 1 was a mixed method studies. And so I mentioned that some of these studies used focus grouped interviews. About 11 of them did. 2 of them used community-based participatory research methods. 3 were phenomenological qualitative studies. 2 of them were quantitative in nature. And in terms of sample size of these studies, they ranged from 8 to 1,243 participants in the studies. So there's a
Wow.
wide range. Yeah, there's quite a big range. And they were from all over the United States. The majority of the studies were took place in the Midwest, but they were actually from different parts of the United States. The majority of studies included participants that were actually in the postpartum period. And the majority of the studies included participants who identified as Black, African American, Hispanic, or Latinx.
Okay. Well, you talked about that you had 2 overarching themes framing the results of your integrative review, the theme of racism and discrimination, and also the theme of unmet information needs. Could you talk about each of those a little bit and explain to people what you found, what you found in the studies you reviewed?
Yeah, happy to. So when we talked about the overarching themes, as I mentioned, we had those predefined factors and outcomes, but these overarching themes actually encompass both those factors and outcomes. So racism and discrimination and unmet information needs, and that was not only a factor in the communication, this relationship, but also an outcome in both those overarching factors. So in terms of racism discrimination, this was defined as receiving poor treatment from prenatal providers due to their race, ethnicity, and different social identities, such as English language proficiency, insurance type. And so there were about 10 articles that specifically mentioned this when we did the review. And the participants from the studies reported accounts of interpersonal racism and also structural racism, which really prevented and also, there's also one study that talked about structural racism, which prevented Black birthing people from having a desired home birth. Additionally, experiencing racism and discrimination, it led to barriers to really good communication, which of course led to mistrust and poor quality of care. The other overarching theme of unmet informational needs really referred to when pregnant people wanted more information, but they didn't have their questions addressed or had their questions just went unanswered. There were 9 different studies that found that pregnant people actually had unmet information needs. And oftentimes this was relayed and they thought that it was perceived that the provider actually didn't care about them, or they thought that the provider actually thought they wouldn't understand the information that would be given to them. As a result, the information was actually met. Studies had demonstrated that information was met by talking with family and friends, and also met by online communities or just online in general. Often having those unmet information needs left pregnant people fearful and also not prepared for birth.
Wow. Not what we want to see happening, is it?
No, not at all.
So to build on that, then, could you talk a little bit and summarize you've talked about factors and outcomes and talking about those overarching things. Could you say a bit about each of those factors and the outcomes that you were able to identify in your analysis?
Sure. There were 6 different factors. And when I talk about factors, these are, things that facilitated, hindered, or influenced communication between pregnant people of color and their providers. So the first one that we found in these studies were provider behaviors. So multiple studies noted that personalized, direct, thorough conversations really helped to facilitate quality communication. For example, providers who asked questions, they allowed for questions, made eye contact, made small talk. These were all mentioned in some of these studies. And on the other hand, some studies mentioned there were other behaviors that hindered communication, such as providers who seemed very rushed, who appeared busy, and didn't take the time to explain things and just had no desire for direct communication. So that was one of the factors. Other factors included language barriers. Some of the studies highlighted the lived experience of birthing people from who immigrated to the United States, who may have had English as a secondary language. So of course, I know this was definitely a barrier to communication. Additionally, there were other structural barriers such as difficulty getting insurance, transportation to actually get to the appointments, long wait times, inflexible appointment times. Additionally, this was a factor that I really liked was provider type. And of course, midwives were named as the providers who actually helped to facilitate communication. I was very happy to see that. And then, of course, another provider type, different provider types that were mentioned was having a provider that was racially concordant with the birthing persons. So there's some race concordance, and also female providers. They also were highlighted as preferred provider type. Additionally, other factors were continuity of care. So a big facilitator for quality communication was seeing the same provider for every single visit or most of the visits. And of course, the barriers came when they saw different providers because they felt like they needed to repeat themselves or had heard the same questions. The last factor was fear, which hindered communication, of course, which then ultimately led to other adverse outcomes. Moving on to the outcomes, these were defined as participants' self-repeated communication experiences with their providers and what came about due to that. The first outcome was disrespectful studies report. Another outcome was trust. Participants felt like trust was a positive outcome or an outcome of positive communication, and conversely, mistrust resulted from lack of information or conflicting information from different providers. Another outcome was decision-making power, where positive communication led to people to be able to have strong convictions in their own decisions, and then those who had poor communication reported lack of decision-making power. Missed appointments was another outcome of poor communication. And then the last one was lack of satisfaction or satisfaction with care. Multiple studies really talked about how satisfaction with care was due to positive communication with their providers, and vice versa. Dissatisfaction of care was linked to provider behaviors, distrust, lack of continuity of care. A lot of those factors and outcomes were actually interconnected.
Was there one outcome before trust? I think we had a funny blip in our connection across the universe. And if there was an item before trust, would you just say that again?
Oh, sure. Did you not catch the disrespect?
Correct.
And respect. Okay, I apologize for that. So yes, it was disrespect, which, as we know from a lot of our qualitative studies that we've read, birthing people of color do often feel disrespected when communicating with their prenatal providers. They feel like their concerns are dismissed or ignored.
Wow, that's a lot of really good information. So, the next thing I'd like to ask you to talk about is, can you tell our colleagues, our listeners, what can they do directly in practice every day to get around some of these things, to provide better care and avoid some of the problems with communication that people experience?
Yeah, Melissa, no problem. So thankfully in, the review, it was very convenient that actually many of the studies actually offered recommendations. So I'll just talk a little bit about that as well. So again, it was one of our predefined categories. There were three major recommendations that were offered. The first one was culturally congruent care. So 9 different studies actually talked about the importance of having a provider that looked like them or spoke the same language as them. Several studies talked also about if there was not a provider available that spoke their same language or looked like them, having some sort of cultural broker, such as a doula or interpreter or community health worker that could be there that could provide those sort of support necessary to that birthing person. Another recommendation talked about provider trainings, not only on sort of anti-racism training and implicit bias training, but actually training on communication and quality communication and how to provide culturally reverent care. Trainings to be able to, in schools on how to listen to patients and how to actually operationalize shared decision-making. The last recommendation that goes hand in hand with the first recommendation that I mentioned was really focusing on the perinatal workforce and really being intentional in growing the perinatal workforce in ways that really diversify the workforce, but also expanding the midwifery workforce. As I mentioned, midwives were named as being facilitators of good communication. So, why not, invest in, midwives of color?
Absolutely. Absolutely. So, some of the things you've talked about kind of reach into the system level, which I'm going to ask you to say a little bit more about. And what about the midwife who's just sitting down next to the next person that's come to see them for that day? What would you say to that person in a particular interaction that people can think to try to remember to do?
Yeah, absolutely. I mean, I think that it's so hard because oftentimes, as this is the study, this review really looked at pregnancy. We're really looking at sort of those prenatal visits. And as we know, midwives day to day, we're seeing anywhere from like 20 to 24 patients on a panel sometimes, right? Day to day, back to back. And it's really hard to not be overwhelmed with that. And of course, you have the labs you're checking and sort of the inbox messages that you're fielding at the same time. But I think that every birthing person does, deserve that sort of that respect and care. And so just coming to the table, just completely open-minded, and to meeting the person where they are, I think is truly important. Particularly in this political climate, Melissa, I think that it's really important to remember where our patients of color are actually coming from, and how they're coming to you in the world. And so I think just being really conscious of that.
So that's great. Thank you so much for all those pieces of advice for our colleagues. I would be remiss if I didn't ask you what else do we need in the research because you were able to distill down a lot of studies and come out with some real clear and important analysis and recommendations for people. What are you doing or now, or what else do you think needs to be done to further this research to better help clinicians do a better job with their patients?
Yeah, so the way that I took this research was, as I mentioned, so I had worked, I forgot to mention in my background, I actually still I work a little bit in the femtech industry. And so I'd always been fascinated with the way that birthing people and pregnant people are utilizing technology. And so I actually looked at in my dissertation research, digital health equity in pregnancy. So more specifically, I looked at respectful communication and patient portal use in pregnant people of color. And so I found that I had done primary data collection at a local hospital in Boston and of birthing people of color. And I asked them to fill out a survey, looking at their, actually assessing their communication levels with their providers and also their digital health literacy levels, and utilization and how they utilize the portal. And so I found that birthing people of color who actually had higher use of the portal actually reported higher levels of respectful communication. So when we think about that, we actually have to then think about access to digital technologies, who has access, how people are actually utilizing it. So I think that's one way to take this, and think about how communication can be enhanced, but also hindered by digital technologies. Um, so that's one way. The other way that I think it's important to really look at this topic is thinking about how communication directly impacts perinatal outcomes for birthing people of color. So as we know, Black, Indigenous birthing people have the highest rates of maternal mortality and morbidity in our country. And so having focused interventions on these communities to help to improve communication and quality of care through culturally relevant care is essential. You know, I always think about there's a wonderful commentary that some of our midwife researchers, Noel Jeffers, Ebony Marcel, and Dr. Lucinda Canty, and others wrote several years back about building community midwifery models of care that actually are led by Black midwives. I mean, this is truly sort of, what we need to be doing, I think. And then researching this, right? It's really examining what communication looks like in this setting, where there's abundance of options, the birth settings where you have providers who look like you or speak the same language. You can deliver at a birth center or home or a hospital. Um, and then how does the communication look like, not only in these settings, but across those different communication modalities, in person, telehealth, patient portal?
Wow, really important work. Thank you for that. So, I'd like to give you a chance to give us your final takeaway. We've talked about a lot of different aspects of your research, the research that you did in doing the review, and then also some research that you've done more recently than that. What's your final takeaway to our colleagues that are in clinics or in birth centers taking care of patients every day? What's the final kind of summary that you'd like to leave them with?
Yeah, I mean, I think, particularly for I think it's really important as a midwife to remember that, and not, really not to forget about the fact that we are in positions of power and privilege. Truly, it's just in a systemic, it's already ingrained, right? I mean, the patient is already coming to us, the birthing people is coming to us as midwives and healthcare providers. It's important to continue to remember that. It's also really important to remember the racist roots of midwifery and obstetrics in this country, right? To really inform ourselves of that, particularly when we are caring for birthing people of color. And like I mentioned earlier, in this political climate, we may not have control of much of those systemic issues at this time, but we definitely have the power to provide midwifery care that is rooted in respect, to make sure that every birthing person really feels safe and heard and supported during their pregnancy.
Thank you for that. Thank you for that. So now this is really the hardest question I'm going to ask. Can you give us one sentence to take everybody on their way for the rest of their day?
Abundance.
And what about abundance? One sentence.
Oh, a sentence. You want a whole sentence? Okay.
Well, you can do a phrase if you'd like.
Okay. Well, actually, I will loop it back to the beginning then, Melissa. And I would say, beloved birth 50 by 50, having midwives care for birthing people, have in all different settings, right? I think that's really is the goal.
Okay. What a note to finish on. Well, Dr. Amy Goh, Program Manager for Beloved Birth 50 by 50. Thank you so much for joining us today. And thank you to our audience for joining us for Speaking of Midwives. We will see you again next time. Thank you for joining us on Speaking of Midwives, brought to you by the American College of Nurse Midwives and the Journal of Midwifery and Women's Health. If you were inspired by today's conversation, connect with us through ACNM's channels. The Journal of Midwifery and Women's Health is at jmwh.org, your resource for cutting-edge midwifery and women's health research. See you next time.